Good morning, all.
Good morning, sir.
Good morning, sir.
Live, huh? Okay. Good morning, everybody. My name is Tipeswamy Bilahalli. I'm joined by my colleagues Suresh Ramaya, Rajendra, Shishir, Huli sir, and Sarva Mangala sister and the team from SS Hospital, Davangere. The man of the show today is Mr. Shivanand Saurgi. He is the surgical theatre practitioner working in NHS over last 10 years. Mr. Santosh, can you keep your mic mute? Okay. Can I request all the participants to keep your mic on mute, please? Shivanand is going to present about pressure ulcer management. The idea is about giving you an idea of what is being evidently practiced currently in UK, and he's going to discuss some UK-based guidelines of what is being currently practiced. This is for you to take this message forward and see how best you can implement it. So he's going to discuss about how to categorize pressure ulcers, how do you manage pressure ulcers, what are the dietary management, wound management, and follow-up plans. So over to you, Shivanand.
Thank you, Swami. Screen share. Hello. Good morning, everybody.
Good morning.
Okay. Today I'm going to speak about the pressure ulcer prevention and management. So let's see what it's pressure ulcer prevention and the management, how we can work in the ward setup, in the clinical or in the house, how we can prevent the pressure sore. Hello, can you please mute your voices on your side, please?
I've done it.
So today the learning objectives is, so we're going to learn the importance of pressure injury prevention and its impact pressure injuries have on the patients, pathophysiology of pressure injuries, and to identify the at-risk areas, skin and how its significance in prevention pressure injuries, equipments available to help prevent and manage pressure injuries in clinics. Excuse me. So the prevalence of the rate, especially in the developed countries like UK, USA, and Canada, so it's around 4.7% to 32.1%. The patients has been admitted. They developed pressure injuries in the hospital care setups, and in the community is around 4.4 to 33%. And in Europe is around 18% of the patients were admitted. Around in 5 different countries, according to the survey, nearly like 6,000 patients were admitted. They developed pressure injuries. So overall, in the recent years, so they have put lots of preventing measures. How to prevent these pressure injuries? What the best they can do? They implemented lots of different techniques and methods. From the last few years survey, it has showed that so there were nearly like 19%. It has gone up to the 1%. So it is not because of any robotic, any equipments or any kind of tools they use. They just use like a simple adaptive measures on a daily basis in the care. So that itself has helped to prevent developing of the pressure sore. So as you can see, it is one of the huge cost, especially in the UK, if I can say, it's really costing around 1.4 billion and 2.1 billions of cost in just treating the pressure injuries. So if you say, hello?
Shivanand, sorry, the lost connection in Davangere.
Can you hear me?
Yeah, I can hear you, but they lost the connection in Davangere.
Oh, they lost connection.
Mm.
Can I stop?
Yes, please.
Okay.
Sister. ನೀವು
ಮತ್ತೇನು
ಬಂದ್ರು ನೋಡಿ ಚಿದಾನಂದ್
ಸರಿ ಸರಿ ಈಗ ಬಂತು
ಚಿದಾನಂದ್
sir.
you really have to fix your computer, guys. You need to upgrade your system. This can't keep happening. This is the second time in a row, because there are other colleges are online as well. If you don't fix your IT problems, you'll have to cancel it. You speak to Kalapa sir and get it fixed ASAP. Okay. Thank you.
ಓಕೆ
Okay, carry on, Shivan.
Okay. So,
ಅಂತ ಸ್ಕ್ರೀನ್ ಮೇಲೆ ಕರೆಕ್ಟ್
so welcome back, the group. So I was telling about the annual cost of the pressure injuries, especially in the UK, is around like 1.4 billion to 2.1 billion in pounds. So if we compare average, so per patient treating in the hospital, it is costing like nearly 10,000 pounds. It is like nearly on the average per patient, it's costing like 10 lakhs or 11 lakhs if you compare in the Indian rupees. So that's just for the pressure injuries management. So the fact is, the pressure injuries, it is involved not only from the doctors or nurses, it's quite multiple group of people is involved, especially in the hospital or in the community. Like example, in the hospital, the nurses has got a huge role in preventing this pressure sore or managing pressure sores. And physiotherapists, the occupational therapists, social workers, and the dietitians, they all got a very, very important role in treating these pressure injuries. And surprisingly, uninterestingly to know, 95% of pressure injuries are avoidable. So if you can just imagine, so how much it has got a like importance of our care in treating this pressure injuries. And one who got this pressure injuries is really extremely uncomfortable, and in severe cases, if it is not treated very well, it can lead to sepsis or infection, and even that it can lead to the death. So it is very, very important. We need to take care of our patients. Okay, the definition. So according to the European Pressure Ulcer Advisory Panel, there's the NPEAP. So pressure injuries are localized injury to the skin under the underlying tissue, usually over a bony prominence, as a result of a pressure or a pressure in combination with shear. So pressure injuries is also called pressure sore, bed sore, or decubitus ulcer. So let's see the anatomy of the skin. As you all studied, this is the looking to the cross section of the skin. The skin is made up with the three important layers of the So epidermis, dermis, and hypodermis. So as you all know, that skin has got lots of other important organs like blood vessels, the nerve endings, subcutaneous fat, all these things. So if you know about the skin, it's one of the largest organ in the body. It can weigh nearly 3 to 4 kilos itself, and is one of the continuous growing and repairing, and in skin, and it can varies in the thickness. So the thickness you can see on the sole of your foot, and thinnest on your eyelash. So functions. So skin has got a varieties of functions. As you can see, it's got a protection, a barrier to the infection. It works as a pain receptor, a production, maintenance of body temperature, and the communication. So if you can see the communication, the patient is, if he's touching and if he's feeling any pain, you can see he can express he's got the pain through the verbally. So when you touch a patient, if he's saying, "Oh, I have a pain on my hand," when you touch, so that indicates there is some problem underneath the skin. So that's how you can communicate, and you can see so the patient has got some skin problems. So there is factors for the skin changes. So the various factors is involved. So like body shape and size. So certain aspects like undernourished or malnourished, and the overnourished. So the high BMI patients or the low BMI. So they got very very important factor in causing the pressure sore. Nutrition and fluids. Again, malnutrition, dehydration, immobilities and inactivities. So most of the patients, this is one of the important factors. Like those people are those immobile, like wheelchair-bound patients or spinal injury patients, anybody with the neurological problems. So those who cannot mobilize, they are very, very prone. And those kind of patients, they require a lot of our care in moving and keeping them active. Incontinence of hygiene, again, this is going to be taking very, very important role in causing the pressure sore, especially fecal incontinence or urinary incontinence or excessive sweat or the body fluids oozing in the body. The age, as the age advances, so this is one of the things, the skin becomes fragile, their body's immunity becomes low, and they are very prone to develop the pressure sores. As you've seen a few slides ago, between 2 to 4, the patients developed pressure sores in the ICU treatment place. The patients were all elderly patients. Medical conditions and medications, again, it's all depends on the like a CVA, diabetes, epilepsies, neurological problems. All these varieties of this medical problems is it's involved. It causes those patients are very prone to pressure ulcers. Considering like a diabetes, patients with diabetes, they get the diabetic neuropathies. So where they don't get much sensation on the organs, especially in the feet, diabetic feet and all, so they don't feel the sensations. So where they get the pressure sores and like a gangrene or the skin is getting, the pressure sore is getting more worst. So but they don't feel the sensation. So this is one of the other kind of problems. Certain medications interferes, like some patients, they are on the corticosteroids. They all delays in the wound healing. Those are some of the medications. The smoking, again, is one of the things. It's very dangerous in all the aspects of our health. So this is especially interferes with the blood circulation, and blood circulation is very important to keep our skin healthy, as it provides the oxygenations and good nutrition. So this will interfere with that. So anything external forces, any forces, pressure, that all will cause the pressure sore. So we have to consider. So now let's see the causes of pressure ulcer. So there are 4 main factors. So the first is the pressure, shear, friction, and moisture. So when you see the pressure sore, you always see that something only like a pressure is happened and the patients develop the pressure sore. But there are multiple factors is involved, like as you see, shear and friction and moisture. The shear and friction or moisture, they don't come. They're not completely making the causing the pressure sore, but it is contributing towards the pressure sore. let's see what is in by individually. So pressure is a perpendicular load of force exerted on a unit of area. This could be a patient's body weight bearing down on a hip or sacrum. So when you see a perpendicular force is happening on the soft tissues, so over the body prominences, what's causing is the capillary occlusions. So where there is a reduction of blood supply and the oxygen. So when the pressure is occurred on a smaller surface, it causes more damage. But when the pressure is occurred in the larger surfaces, so the distribution of pressure is less. So especially on the bony prominences, especially in the sacrum, on the trochanter areas, or the heels, or the back of your shoulder. So those are the main points of pressure areas. When constantly lying, so that's causing the pressure. So according to the research studies, when you see, so there is up to 60 millimeters of mercury, the pressure is applied over an hour. So that is significant amount, significant time itself. It's the pressure is happening where it will be cutting off the pressure pressure. So if you imagine, if you put a blood pressure cuff on a patient, and if you are taking the blood pressure just for a few minutes, you're taking, there's already, you can see there's a discoloration on his arm when you remove the cuff. Even if you take example, like you're taking the blood, you're putting a venflon or taking the blood, so you're putting the tourniquet. So again, you can see there is a difference in the circulation. So that is what is like a few minutes. Just imagine if you're sitting on one place for longer duration without moving. So, and like more than 2 hours or 3 hours, that itself will cause a huge significant amount with your blood circulations. So as you're sitting and watching these videos, unconsciously yourself, you will be moving side to side or moving your legs. So this unconsciously you're doing it to relieve your pressure. So that in the hospital, when the patients, so they can't. So they need a high care. Sharing. The sharing is like a pushing or pulling the skin, means more than one layer of the skin slides each other. And that can cause a damage on the layers. So as you can see on this picture on here, so the pressure is causing from the perpendicular pressure. You can see the arrow is going down over the bony prominences. Whereas the shear is, it is on the side to side. So when, for example, you're transferring a patient from the bed to the cot sides or the another bed. So when you're transferring, imagine if the patient's skin is stuck on the bed and you're moving, so the body is moving, the skin is coming later. So the bone inside is rubbing on the soft tissue, soft skin, soft cells. So that itself is rubbing and it's causing the like a pressure show. So there is a stress side by side. So that stress is causing there's like a vasoconstriction, and that when it occurs persistently, so there is a significant amount of pressure. So when the patient is like elderly and fragile, so there is a less fat between the skin and the bone. So where that's why they are very, very prone to get the pressure sore, because their subcutaneous fat is less. And also on the top of that, their comorbidities, anything like diabetes or vascular problems. So that all will be adding factors. Friction. The friction is like the two surfaces is rubbing together. So that could be the skin and the bed sheets, or on a air cushion, chair or the cushions, or a poorly fitting clothing or manual handling aids. Excuse me. So this the friction is especially the patients, the convulsion patients, or patients very highly uncomfortable patients on the bed, patients with dementia, patients who need care and they cannot able to speak, and they are very, very uncomfortable on the bed. They would be moving their the elbows or the heels on the bed. So that itself can cause a friction. Just imagine you're wearing a tight, excuse me. Just imagine you are wearing a tight shoes, you're walking, and you can see on the back of your heel sometimes a sore develops, and that's you can see the picture on the back of this heel here, the excoriation of the skin, how you can see this. So the friction, it's very, very poor manual handling techniques sometimes cause the friction. So we have to be very, very careful, especially the patients when you're handling while you're giving care. Giving an example on the operation table when the patients after the surgery. So you are transferring patient from the operation table to the trolley or the bed. So you're putting the pad slide. So when you're putting the pad slide, so you will be putting a slide sheet underneath to transfer. So suppose your patient's is like a heel is not completely covered with the slide sheet and you transfer. So that the skin when it coming in contact with the pad slide, and that slide can cause a friction and that can cause the wound like this. So this is very, very easily preventable. It's not something rocket science, it has happened. So it is preventable. So you have to just be careful when you're transferring the patient anywhere from the bed to the other bed or the trolley, or even if the patient himself is on the wheelchair, also is so to prevent friction. So give him enough support like a pillow or any cushions. Excuse me. So the moisture, you can see the picture on the right hand side. There is a multiple areas. There's a superficial sore. So moisture is usually happens because of the incontinence of the feces or incontinence of the urine, excessive of the drainage or the perfusions. So with the moisture, which as you can see in the science, the skin's pH is acidic. So when during the incontinence of urine, the urine's pH is acidic, and when the urine is producing the nitrogen is coming in contact with the skin, it causes into the alkaline, and that makes the skin break down. So whereas the fecal incontinence, the fecal it produces lots of bacteria, and the bacteria when it's coming in contact with the skin, that will produce the pressure sore like this. So again, this is not the pressure sore, but it is a contributing towards the pressure sore. So that's why it's very, very important when the friction or moisture or these are the highly preventable care. You can care with the patients. So the moisture related one, keep the patients dry and give the good hygienic care, so that itself will prevent developing the pressure sore. So here, the difference between the pressure versus the moisture. So with the pressure, you can see in this, it's a defined shape and after circular, and it's non-blunt. And it's more on the. Somebody mute the volume, please. Hello. Okay, thank you. Okay. So the pressure versus moisture, if you can see this pressure is more it's a defined shape and often circular, and it's non-blanching. It's more on the bony prominences by the either under direct pressure or from a medical devices also. Whereas the moisture, it's got the non-defined edges and may have jagged edges and it's blanching, and it's got multiple wounds it may be present, and it is due to the overhydration of the epidermis, which can result in the skin loss. Excuse me. So let's see pathophysiology. What causes the pressure injuries? So there is a short video. Please have a look at it.
Shivanand, I think you have to enable the voice. Shivanand,
Hello?
no, there's no audio.
Martha, full volume ಇದೆ.
We can't hear. I think there's a problem with the audio.
The video ಕಾಣಿಸ್ತಾ ಇದೆಯಾ?
Video is okay, but no audio. Suresh, can you hear the audio? No.
Embedding problem ಆಗಿರ್ಬೇಕು. Embedding problem ಇರಬೇಕು.
I'll just 1 second.
ಸ್ಕ್ರೀನ್ ಶೇರ್ ಮಾಡ್ತಿದ್ದೀರಾ ರಾಜೇಂದ್ರ?
ಒಂದು ನಿಮಿಷ. Is it audible?
Shivanand,
I'll come back with that one, please.
why don't you Rajendra, you got the link, right? You got the video link.
Yeah, I do.
Why don't you put that in the chat box?
No, 1 second, 1 second. Now it will come, definitely.
Ilandra Rajendra, shall we continue and you can come back to that video later?
It will play now, definitely.
Pressure sores, also called bed sores or decubitus ulcers, are regions of skin that break down when you sit or lie in one position for too long. These wounds occur most frequently in areas where your bones are close to the skin, including your heels, ankles, hips, tailbone, or elbows. Constant pressure to one of these areas compresses the blood vessels that supply your skin with oxygen and vital nutrients. Without a sufficient amount of blood flow, your skin cells eventually die, and a pressure sore forms. Pressure sores are categorized by degrees of severity. A stage 1 pressure sore is reddened, inflamed, and does not blanch or become pale when pressure is applied. A stage 2 pressure sore appears as a blister or an open sore. The area surrounding the sore may be red and irritated. A stage 3 pressure sore involves a full thickness loss of skin that appears crater-like and extends to the layer of fat beneath your skin. Stage 4 is the most severe A stage 4 ulcer is a full thickness wound that extends down to the underlying muscle or bone. In 2007, the National Pressure Ulcer Advisory Panel added 2 more ulcer stages: suspected deep tissue injury and unstageable. Suspected deep tissue injury is a maroon or purple area of the skin and may contain a blister filled with blood. It looks like this because of damaged soft tissue underneath your skin. An unstageable ulcer is a full thickness loss of tissue. However, the amount of tissue loss cannot be determined because the ulcer is covered by dead tissue. To prevent infection in your pressure sore, your doctor will clean your wound using water and a mild soap or saline solution. If your wound is severe, your doctor will debride or surgically remove the dead tissue from the pressure sore. To protect and hydrate your wound, your doctor may cover it with a specialized bandage.
I think.
Okay, Shivananda, please take
Yeah.
over.
Okay, so you've seen this video. Hello. So you've seen the video. So that video has given an explanation how the pressure injuries happens and what are the different stages of the pressure injuries. So this is the another picture.
Interrupt. You need to share the slides once again. And please include the audio before sharing.
Hello. Second. Yeah, can you hear me? Can you see the?
Hear you.
Okay, sorry about that. Okay, we come back now. So, okay. So with the pressure injuries, you can see.
You can't see the slides.
Can't see the slides, huh?
No. Can you share your screen again?
1 second. Share.
Please include the audio before sharing.
So 1 second, please. Here, share content. Share. Can you see now?
Yes.
Okay. Right.
Good.
Can you see? Can you hear me?
Yes, you can.
Okay.
Yes, you're audible.
Thank you. Okay. So in the previous one, you'd seen the slide. What's the pressure injuries? How does it happen? And what are the different stages of the pressure injuries? So now let's see a little bit in this picture. This is the normal skin on the left-hand side, what you see with the bone, soft skin, blood vessels, and skin layers. And on the right-hand side, you can see there's a hard surface and friction of the skin against the surface, pinching of the blood vessels, and pressure of the bone against the hard surface. So anything you are putting a pressure on the bony prominences, so that pressure is causing a pressure on the blood vessels. So that will diminish the blood circulation and oxygenation. And when it happens continuously for like a longer duration, that will lead to ischemia. That is the ischemia leads to they cause damage to the skin. So this itself is how we can prevent is by moving the patient. So by moving the patients, the circulation comes back to provide the oxygenations in the blood vessels, and the cells will get the nutrients, and it will become normal. It will become healthy. So now next is classification of the pressure source. You've seen in the video just a few minutes ago. So there are 4 stages, and then 2 more has been added, and they are deep tissue injury and unstageable. So now you can see, just for easily remembrance, imagine an apple. So think of a red apple. If the red color will not go away when to touch, this is like a stage 1 pressure ulcer. So it will not blanch because there are already signs of capillary compromise within the layer of the skin. So in the stage 1, you don't see any kind of open wound. You just see a kind of non-blanchable redness on the localized area, very on the bony prominence, not everywhere. Like a skin disorder like eczema is not, that's not the one. It's just on the bony prominences. We just see a non-blanchable redness. So that is red. That is the stage 1. So when you're giving a patient, for example, patient is on the bed bound and you're going to give a bath, then you see a redness on the elbow, on the sacrum. Just imagine that's a stage 1 pressure sore. There's nothing else. You don't need to think anything. That's a stage 1 pressure sore, and it needs some kind of action. Okay. So then next is the stage 2. In the stage 2, so just think of this again in the apple. So it is being peeled where you just want to remove the skin, and you can see a portion of the skin has been out. So in the stage 2, what happens? If you see, there is an involvement of the epidermis and the dermis. So there is a shallow open ulcer with a red-pink wound bed. So this is a stage 2 pressure sore. It is like a blister in the sort of formation, clearly filled with the fluid. So that is your stage 2. In the stage 3, again, if you think of the apple, so when you have like a good bite of an apple, so that is the depth of the apple pieces come out. So in the same way, in the skin, we see that there is a full thickness loss, or subcutaneous fat may be visible, but there is no bone or tendon or muscle spin involved here. So there is you can see a big chunk of the skin has been out, and the final stage is that the bone, bone is there, but it's not been exposed yet. So that's your stage 3 pressure sore. And in the stage 4, if you can just imagine an apple is completely almost like you're finished eaten, and the final portion is there that you are going to throw it out. So that is almost like the skin is gone. Yeah. So in this stage 4, there's a full thickness of the loss or expose of the bone or tendons or muscles. So where you can see a slough or a there's no necrosis, but just slough, lots of exudation, bad odor, anything. You see all those kind of things here. That's a stage 4. And in certain times, you see a deep tissue pressure injuries. You might have just imagined an apple with like a maroon shape on the localized area. Where is it? On the part of the apple. You don't know how much deeply the apple is damaged. So in the same way, the skin here, you can see the maroon shape on the top. It looks like definitely there is a sore, but you don't know how much inside it, the depth-wise, it's been damaged. So that is kind of like a deep tissue pressure injury is there. And then unstageable. So this unstageable, so this is like a think of a toffee apple, where the toffee is completely coats the apple, and you don't know unknown beneath what is happening. So in the same way, so you can't make any stage here. The skin is got the necrosis. There might be slough or eschars in the wound bed. So anything like this is very unstageable. So this kind of the pressure ulcers needs severe interventions, both from medical team and yourself. And at certain times, you can see a mucosal membrane pressure ulcers. This is due to sometimes you can be using the oxygen, or you can be using the CPAP in the intensive care units. The excessive heat of the oxygen, when it's produced on these soft cells, that can cause the pressure damage. So this is, and also sometimes when you are using the suction. So during the suction, when you're putting the tube in the nose to give a suction, that itself also give damage the soft cells here. So just imagine when you're going to treat the patients for pressure ulcers, stage 1, stage 2, stage 3, stage 4, and the deep tissue injury and unstageable. So whenever you go to see the patients, keep an eye on the patient's skin. By the look of the wound, you can able to just get a glance what it is, what stage it is. So now next we'll move on to the signs and symptoms of the pressure ulcer. So the signs and symptoms you can see when you touch. Sometimes it will be cooler or warmer to touch, and there may be sometimes changes in the color or the texture, tenderness, pain, reduced capillary fillings, or blanching, or swelling, or wound discharge. So it depends on the pressure ulcers. Sometimes if the pressure ulcers involved with like a cellulitis, or sometimes with the osteomyelitis. So you may come across a different sorts of like a sepsis sort of symptoms. It may be fever or the shivering, or it could be your blood, your analysis will be disturbed. So anything which is different symptoms, so always linked into the pressure sore. So working in the clinical area, there was a patient, if I can give an example, he had a pressure sore, and he developed the sepsis. He was shivering, and he had like a convulsions kind of symptoms she was exhibiting. So when the doctor came, he looked around, he took the bloods, and he took all the vital signs, everything is monitored. So the main cause, they did not know until we mentioned the patient had a pressure sore. So when they opened the wound was infected. So that itself, the infection has caused, and it is spreaded into the other parts of the body, and then where the patient was showing the symptoms. So whenever the patient with the pressure sore is showing any symptoms, keep an eye that is it the wound is not infected. So just one question to yourself. So now, where do pressure injuries occur? Oh. Sorry. So can you hear me? Okay. Okay. So where do pressure injuries occurs? So pressure injuries occurs depends on the position where you are. So looking at the diagram here on the left side, where the patient is on the supine position, it could be back of your head, shoulder, elbow, buttocks, or heels. If you are on the lateral positions, it could be either left lateral or the right lateral. It could be on the ears, shoulder, elbow, hips, thighs, legs, and heels. And sometimes you may have to put the patients on the prone position. So in the prone position also, the patients develops the pressure sore. So those are the areas like elbows, rib cage, thighs, knees, and the toes. And this is the supine position, sitting position. This is the most common the positions where you will see the patients develop the pressure sore. Because especially in the ICU, patients are washed and dressed, and they will be placed in a sitting positions or on the bed. Because if they're not able to transfer onto the chair, you will be sitting them on the bed. So this is, and also on the ward setup, if the patient is elderly, they can't able to sit on if you think the patient is risk of falls, you will be placed him on the bed with the cordsets up. So again, they'll be in this position. So, but imagine those areas, they are very, very prone to develop the pressure sore. So if you think of this, like a supine is the highest, like 23%, especially sacrococcygeal areas develop the pressure sore. If they are in sitting positions, around 24% is involved with the ischium location. And if you're in the lateral, again, 15% trochanter area is involved. So it is like you're putting the whole, your body weight on the base. So that is where you are putting lots of pressure. So pressure is also pressure injuries can also happen because of some medical devices, like wearing the tight mask, the compression stockings, and the oxygen is delivered through the nasal cannulas, and the PEG tube sites, and the NG tubes, the collar necks, the plaster of Paris, and even the tracheostomy sites. So especially like in this COVID crisis, treating the patients in the ITUs or wearing the PPE kits, you can imagine how much you're all facing the difficulties wearing the tight mask for the longer duration. When you remove, and if you look at the mirror, you can see there is a significant mark on your skin. So it is, and imagine the patient is having the oxygen mask for a number of hours in the ward or in the clinical settings. Just imagine if with their medical condition and on the top of this wearing mask, their skins are very, very prone to develop the pressure sores. So we have to look after ourselves and also look after the patients, those who are all with the medical devices causing pressure sores. So the Waterloo score. So this Waterloo score, it is the important tool. There are lots of tools are used to assess the risk of the patients. So there are sort of like a Braden score is there, and the Waterloo score is there. There are different tools are there. So you might be using this Waterloo score quite commonly in your clinical setup. So as you can see, the score itself will be given based on the pointing systems. If the patient is obese or thin, is above average or below average, and also if the patient's skin is healthy or tissue paper or edematous or discolors. Again, if the patient is male or female or they're on the age, and we do the malnutrition screen. So whether the patient has lost the weight or and also the continence, whether the patient is catheterized or whether is fecal incontinent and his mobility. Based on the condition of the patient, you've seen the patient, you assess and you put the points, and whatever the points comes, anything 10 plus is like at risk, 15 plus is the high risk, and 20 plus is very high risk. So based on the points, you need to take some action how we can prevent the pressure sores. So we're like very high risk patients, they're very, very prone to develop the pressure sore. So what are you going to take the action to prevent? So that's the one thing you have to use your clinical judgment. So now there are 5 important things you have to follow in your clinical settings. So they are the surface, skin inspection, keep moving, incontinence, and nutrition. So these are the 5 acronyms. So we are going to discuss in next few slides how we can prevent and manage your patients in developing the pressure sore. Sorry. So this is the think skin steps. So they are these are the greatly assist the prevention of pressure ulcer. If a patient has an area of the concern, think of the skin or start the skin bundle. As I mentioned in the epidemiologies, about in the UK, a few years ago, there was 19% gone to the 1% in the prevalence of the prevention and management of the pressure sore. It's not just due to anything they introduced, it's just purely following this yes skin, the guidance. Okay, now let's see one by one. Rajendra, would you like to ask a question about the quiz? Rajendra?
So
Rajendra?
just I'm going to post one quick question in the chat box. Yeah, is it okay now? Yeah, so we have posted the question in the chat box. It's a online Google form. Try to fill that one in 1 minute, and we'll display the results soon. So question, and with the possible choice questions, answers are there in the question only. Yeah. Oh no, actually it comes with a multiple choice. Can you share this link in the YouTube, please? The question. That's okay. We'll leave it. We'll come back for the answer and we'll work around that one. Okay.
Okay.
Sharon, please continue.
Shall we continue? Okay. Thank you, Rajendra. Okay. Yes. Yes. Sorry, what is the question? SHEAR, yes. The shear is what we discussed earlier, is when your body, okay, let's say your body is stuck on the bed. Yeah. So suppose if you want to slide your patient up, so you dragged your patient towards the upside. Okay. So the body weight is there on the skin and you dragged. So if you did not use your slide sheet, so you're dragging the patients upwards. So your skin is intact. So the bone, you're moved a little bit, but you're not moved the whole patient. So it means the bone is rubbing underneath the skin. So the soft, it is putting lots of pressure underneath your skin, and it is rubbed towards the like a few movements upwards. So that is a kind of called as a shear. So when that's you're doing that persistently, frequently, so you are damaging the cells or the soft cells or the tissues where it is causing shear inside by preventing the circulation and oxygenation to the tissues, and it is contributing towards the pressure sore. Is it clear, this answer?
Thank you, Shiva.
Okay. Okay. So now, according to the acronym, the first is the surface. So you've done your Waterloo score, and then you have come to a conclusion. Yes, your patient is on the high risk. His score is like a 20 plus. So now, what is your action? So you need to put a patient on the special mattress. So there are lots of different mattresses are available. So you can see one is a soft foam mattress. It's just like a soft cushion. So you will be placing any pressure, any pressure sore patients with the mild pressure sore, like say like a stage 1, like a grade 1 pressure sore. Yeah. So you're placing this patient, that itself is not enough, like preventing. You have to do something else. But this kind of soft foam, it is going to help. It's like a pressure relieving type of cushion. It's going to help preventing the further damage. Okay. So on the left hand side, what you see, there are different varieties of brands are there. The air mattress. So the air mattress is like it works on the motor like a pump. You have to adjust the settings here. So you need to have some sort of training to handle this. So especially in the UK's hospital setup, when the staffs are handling this one, they provide a kind of called as a green card. So with the green card, that means not everybody can handle. So, but they have to have this training. They can, even your ward managers can give, or one of your team member like seniors who knows, they can give the training and they can sign off your green card. So, but in your hospital, in your starting day, they will teach all these kind of things. So you will be knowing what it is. So there are different sorts of pumps are there, and also there is a hybrid mattress. Then there is also according to the mattress, there is a cushion also is available. So when you are nursing the patient on the bed, you want to transfer onto the chair, so you will be using the air cushion. But you have to be, one thing is you have to remember is always you need to plug the air mattress into the pump, otherwise it won't work. So, but it can retain the air inside when you're transferring the patients, for example, transferring to the scan, CT scan, MRI scan, or transfer to the other unit for investigation purpose. It can hold the air, but certain duration. Then afterwards, it will be keep going down, so you have to put the pump back again. So now there's another short video. So this is just an awareness about the modern, how much the technology has been developed. So this is a self, like a tilting the mattress, but it is got some kind of contraindication to use for some neurological patients or the epileptic patients or patients with the dementia or the Alzheimer's. So those kind of patients, it is contraindicated. But for other patients, like patients with the pressure injuries, and they can manage themselves, they can use it in the house setup. If they can able to afford, yes, they can have this one. Just to have a quick video look.
Audio is not playing.
Rajendra?
I'll share from my side, 1 second. Sorry, 1 second.
Please, sir.
Okay. Audible?
Yeah.
The Toto patient turner is clinically proven to help with tissue viability and delivers results unlike anything else you've used before. It is a The Toto patient turner is clinically proven to help with tissue viability and delivers results unlike anything else you've used before. Non-intrusive, affordable, yet highly effective 24-hour automated pressure relief system. The Toto's unique lateral turning action tilts the body smoothly and quietly without initiating a roll, and its gentle lift and whisper quiet operation lets patients sleep soundly throughout the night without the disruption of being manually turned. The Toto Patient Turner can be used on any bed, whether flat or profiled, and beneath any mattress, gently tilting the patient to 30 degrees on an automated cycle. Its simple operation and programmable cycle make this an easy-to-use, effective, and low-cost solution for both acute and home care. Faster healing and increased comfort accompany quicker discharge times and reduced care package costs, reuniting families, saving money, and improving the quality of life for countless people. GINA Care, safety and care for those in bed.
Thank you. Back to Shivananda Ranimage.
Okay, thank you.
Sir, Uli sir wanted to ask a question. Sir, do you have a question? Uli sir? Uli sir, do you have a question?
Of course, I think we move on.
Okay.
All right, carry on. Sorry, Shivan.
Okay, that's fine. So you've seen the video just now. So it is so this is one of the modern like a mattresses. It's not everybody can afford or anything. It's just for just an idea what are the mattresses are available on the market. So that's I just thought to show to you. Now the next move into the other pressure relieving like equipments. So they're like you've seen like a dynamic mattresses, the air cushions, and there are some like a repose boots, as you can see on the right hand side. So this is to help to prevent the pressure source on your heels. And the slide sheet. So slide sheets are very, very important. You'll be using from head to the toe, to the heels. You need to make sure you cover the whole part of the body when you're transferring your patients. So now we have implemented in our trust, as you can see. So when we are turning the patients, we are highly taking care from back of your head and back of your heels. So we have to make sure the slide sheet is completely has been stuck inside before you're turning the patients and onto the other side of the or putting the pad slides and then turning into the trolley or to the bed. So now the skin inspection, the next acronym is the skin inspection. So skin inspection is just is a part of the patient care. Then early identification of the skin should be assessed regularly and documented, and skin inspection where possible. Ask a patient and listen to the patient if he's got any pain on the body. So just see is there any redness when he says any pain. See is there any redness. So don't just jump into the pain. Okay, you need painkillers. Okay, you need to do that also. But when he says there is a pain on my skin on my elbow, so just see what is the pain. What's happening there? Is there any redness? Is there any tender? Are there any kind of dryness or any kind of color changes? Are there any moisture? Anything obvious things, observe first and then make a clinical decision. So now what do you look for when you are assessing the patient's skin? So remember, when you go to wash your patient, for example, you receive your handover and you go to your patient and you're going to wash your patient. So you see the patient and you see a redness on the trochanter area like this. So what you do next? So there is some redness happened. So the patient lied on the bed overnight, and when you receive it in the morning, you see like this, there is redness. So what you do? So as kind of skin check. So press your finger for 10 seconds and see is there any kind of blanching, whether the capillary refilling happens within the 2 seconds. So if the refillings happens, that means there is a circulation. There is a circulation. If there is no circulation, there is a blanching. So there is some kind of significant interference with the circulation. There is a possibility the patient may develop pressure sore. So this is one blanching erythema, non-blanching erythema test you do when the patient you see the redness. And certain patients, they have got the dark skin. You might not be able to see this blanching or non-blanching when you press. So those kind of times you have to see when you touch, there is any tenderness. Patient may say, oh, I got a pain. You may see hot or cold, and you may see a kind of swelling. So, and like a pitting edemas. So anything, this type of obvious changes. So you may have to see, before you go into the doctor, you just 1 minute, ask yourself what it is, what's going on with the patient. So I received I took the handover and I came and see the patient, and patient got this problem. So immediately you may go and see, oh, doctor has got the patient, so there is redness. The doctor is not going to do anything. So you need to judge, okay, what can I do to to develop this further, causing damage to the skin of the patient. So you need to work on that immediately to prevent further damage. So the next few steps is the 5 steps to the skin assessment. So according to the NICE guidelines, so you see the full inspection is to be done within 6 hours of the admissions. So in the UK, it is like this. Whenever the patient comes to the accident emergency center, from the admission, whichever whether he is staying the A&E for 6 hours, or is going to be transferred onto another unit. So within the duration of 6 hours, the skin needs to be assessed. Someone needs to check his skin from head to foot and then document that. So that's the one important things we have to do. So when you're observing, so again, same thing, condition of the skin, whether the skin is intact or not intact. And you need to do the daily risk assessment. And I will come back to that one in a minute, the skin bundle. So ensure the skin check documented on the skin care plan. And again, so check for is there any discoloration, dryness, cracking, erythema, temperature, pain, hardness, anything like this. And if needed, you need to take a photography and put the photo in your medical notes. So that is to monitor the changes in your pressure sore. Okay, now you see the patient has got the redness on your skin. So now think skin react to the red. So red is RED. Red is repositioned regularly every 2 to 4 hours. And E is your equipment as appropriate, and document is the D. So the skin assessment and skin care plans you're going to start, and you put this safety cross. Safety cross is the one you're going to monitor in your ward setup, for example. So you're going to put the safety cross, like how many patients has been admitted with the pressure sore, how many patients has been treated, how many patients has improved, how many patients has gone worst. So you have a record, a chart, it's showing, say for example, you have 20 patients unit in your ward, and out of that 2 patients has developed pressure sore. So mark in the safety cross 2 patients, so-and-so unit has got the pressure sore. And then again, you keep on monitoring that patients, the improvements in the pressure. So whether it's getting improvements or whether it's getting worst. And in few weeks times, if you get another few patients with the pressure sore, again monitor there on your chart. 4 more patients got the pressure sore. Now you need to be thinking, okay, in your got 4 patients got the pressure sore. Why we got the pressure sore patients, and where it started, how it started, and what are the causes, and what you can put some actions to prevent that. So those kind of things. It's just give a rough guide, idea how you can prevent further, this is happening. And then you're putting like a safety check. Make sure the patient is safe on the bed. Put the cot sides up. Make sure there is no oxygen tubings on your bed where the patient is lying on that tube and it's kinking and also causing pressure on your skin. Anything like this, so you need to monitor the patient is safe on the bed. And positioning like side to side, sit to stand, and suspend the heel by putting some pillows. Now, the next is the keep moving. So the next third acronym is the keep moving. So again, based on your risk assessment, so you need to monitor the patient, put the care plans, turn the patients every 2 to 4 hours. If it is very high risk patients, so you do it every 2 hours. If it is low risk, you can go between 4 to 6 hours. Depends on the condition. If it is the patient is independent, is still got the like a grade 1 sore, educate him, encourage him, ask him to sit and stand when he's on the chair. Try to mobilize under supervision if he's going to the toilet, if he wants to walk. So if he's on the oxygen tube, so you can support him to the walk just around the bed or to the nearest to the nurse's station. So that the patient is keep moving. So there is a circulation is working, and the patients, if got any grade 1 sore, that will help with the improvements. So remember, pressure redistribution equipment is just not enough preventing the pressure sore. So it is works when with the movements. So this is the 30-degree tilt. So as you can see in the picture, the patient is lying on the sideline positions with the pillow support, and there's a support on his elbows. And you can see the trochanter area has been elevated up to the 30 degrees in the positions. So every 2 to 4 hours, you are elevating and taking the pressure off and the load of the pressure on this area. So that helps with the circulation in the body. So and also on the same in the heels. So where you see the bony prominences area is supported with the pillows, and on the knees, again, supported for the pillows. So have a quick look of this video. It gives just an idea. So how they're helping this patient, and they're how supporting how to with the this 30-degree tilt. Yeah. So I'm going to play this now. Is the audio coming again? Audio problem? Can you hear?
We can't hear the audio.
Rajendra, can you please?
I'll try.
Shivanand, we got another 15 minutes only.
Okay.
So I think we'll share this link later on.
Yeah.
Can you play without the audio? It's fine.
I'm going to.
Rajendra, can you put the link in the YouTube in the chat?
Yeah, sharing that link.
Hmm.
Hello, Rajendra.
Yes.
Shivanandar, I think it's the end of the video. You can continue.
Veena, do you have a question? Can you unmute yourself and talk? You raised your hand, Veena.
Okay, Shivanand, please continue. Can you unmute?
Shivanand, can you carry on?
Shivanand, yeah.
Okay,
That's
that's fine. Yeah. Okay. So where are we?
So can you fast track a bit, please, because you've got another 20 slides still.
Yeah. Okay. So the incontinence, which we already mentioned. So make sure your patients are clean and dry. So use sometimes like a barrier creams to protect your skin, especially the patients are developing the IAD, that is incontinence associated dermatitis. Okay. So the now is a nutrition. So nutrition is, so use your must tool again to assess your patient's risk management. So do the weekly weights and offer the like a 4 to 6 drinks, which is like a food nutritious drinks. Keep a food chart, and if needed, make the dietitian referral. So this is the must score tool. You can see malnutrition universal screening tool. So it's got the steps 1, 2, 3, and 4, and 5. So follow the guidelines, and based on the point system. So make the if it's a low risk or the medium risk or the high risk. So make your clinical judgment, and if needed, refer the patients to the dietitian. So again, the factors that can influence your nutrition and hydrations are the age-related factors, the medications, social factors, and physical factors. So again, the patients with the elderly patients and with the cognitive impairments, so they won't be, they need a lot of support with the nutrition. So you need to provide, and certain medications like the diuretics or laxatives. So those patients, those who are on medications, help them to have the good nutrition. And social factors, those like a poverty or social isolations. So they might not be even having access to go and buy the good nutritious food. So those kind of people are very prone to develop the pressure sores with the comorbidities. And physical factors again, like those patients, those who got the swallowing problems, they themselves has got having the take the good nutritious food. Now the dehydration. So the dehydration, hydration helps to promote preventing the pressure sore. So dehydration, what happens? It will be decreases your blood volume, carrying the good nutrition and oxygen towards your the body cells. So hydrating your patients is very important. So especially the patients, they need a support, like those who are the stroke patients. They might need a special cups to hold to drink the water. So those kind of things you need to consider when you're treating the patients on your bedside. So maintain the intake and output chart. So this is very important. You need to monitor how much the patient is drinking in the day. So especially the patients with the pressure sore. So you need to closely monitor to push the more fluids. And some patients might not, like to drink the plain water. So you can add some lemon, some kind of squash, so anything which is available, which is more favorable for your patients to, he likes to drink. You can add that so that to promote hydration. So this is just a simple fluid chart, what we use, just for your ideas. So in the pictures, you can see a different size of the cups, what they're using, and here is the times the patients are patients are drinking the fluids. So put the number of the cups the patient had, and then you make the total. But it is you have to bear in mind also certain patients with the heart failures and the fluid restricted patients. So you have to maintain that also. If the patient needs fluids, it's not that you're pushing lots of fluids. So you also leads the medical condition of the patient when you're giving the fluids. So now clinical management. When certain patients with the like a stage 3, stage 4, certain pressure source that needs the medical interventions. So they might need a surgical interventions as well, like they might need a debridements, they might need vac dressings. So those kind of things will be dealt with from the physicians. And the larval therapies, so this is some very few places, it's becoming more popular. So they're using this one to debride the wound. Nutritional interventions we have covered, and the antimicrobials, certain pressure source like cellulitis and osteomyelitis, kind of infections that needs to be treated with the antibiotics. Okay, there's another short video. Just have a quick look about the Can you hear the audio?
No, we can't hear. Sorry. Sorry.
Okay, back to the okay. So just seen the video just now. Hello, can you hear me?
Yes.
Okay. So just in the video, so just the about there was a grade 3 pressure sore. They were putting a pressure the dressing. So now you can see in the photograph there are lots of different you can see horrible pictures are there on the left hand sides. So especially the first one, it's very deep necrotic non-viable tissues. So they're using a different sorts of dressings for different sorts of the wound. So I don't know in your trusts and your hospitals what sorts of the different the dressings are available, but you can use what is the dressings are available for the for your for the different pressure source. In these hospitals, there is a specialized team called tissue viability nursing team. So they are only specialized in this kind of on the wound therapies on different wounds. So they come and put a plan what type of dressings you can use for your patients, especially like a stage 3 and 4 dressings, and even including stage 2. So in your hospitals, you use your the products what is available, what is the best you can treat for your patients with this kind of pressure source. Okay. And this is the skin bundle. The skin bundle, it covers all aspects about any patients being transferred to your unit with the existing pressure sore or is developing the pressure sore. So you put a care plan and starts monitoring about it. So you start putting like you're putting the pressure like a soft relief mattress, or whether the patient needs an air mattress, and whether his heel is protected, and how often you're going to change the position of the patients, and also whether the patient has got any incontinence problems, and also patient whether needs the again tissue viability team referrals, anything like this. So you're charting this on a daily basis so that you can monitor very closely. So this is the skin bundle. One of the important things in your setups, in India, what happens is when the patient has been discharged with the pressure sore, the patient is being treated by the family members or the carers. They are the main carers. So, and they are in the remote places, like in the village side or very in the not very close to the hospital location. So they are treating. So what is most important is education, knowledging. So those carers are giving the knowledge how to take care of this, especially the stage 2 or 3 or 4 pressure source. So what sorts of changes they need to be seeing. If there is any slough or any necrosis, they don't have any idea what it is. They just know that it's a wound. They just been told that you just need to change the dressing. They are given a dressing and they'll be keep on changing every day. So they don't know whether there is a cellulitis, whether there is any kind of oozing, any kind of the bad odor is changes. So they have educating them, the carers or the family member, if anything like this kind of changes happens, bring back to the patient to the hospital for further investigation. So the patients will be monitored in that way. So what we can provide is if you can make a kind of leaflet with some pictures, give it to the patients and explain those kind of posters, so that they get an idea what to do and what to observe when the patients be treated in their families. Okay, so I just jumped into different things, but coming back to the skin bundle. So again, this is one of the skin bundle is done on the daily basis. The same thing. They are going to assess the wound on the wards. This is the comfort and pressure care records. Since this has been introduced, the risk of falls, pressure injuries has been prevented. So basically, this forms is an indication that you are attending the patients regularly. So it's very important. You need to go and see your patients at least every hour. And when you see the patients, so you can write down what's been asked here. So there are very simple questions. You're just answering there. So this one got like a pressure source, whether you've been turned and which direction you've been turned, whether the patient, if he's independent, whether he's been mobilized. So anything like that, you are charting here. So this is a tool for yourself, how you are monitoring your patient. So now, according to the National Pressure Injury Advisory Panel, so especially it's very important protecting our facial skin, especially in this COVID crisis, as we mentioned earlier. So wearing the PPE for longer duration cause the pressure injuries to ourselves. So we have to protect ourselves also. So we'll go through some few slides here. So keep calm and protect your skin. So the calm is clean, moisturize and hydrate, avoid makeup, limit mask wearing time, take breaks every 2 hours, and monitor for early signs of skin damage. So this is one of the pictures of the front line workers, especially patients, nurses and staff. They are looking after the patients continuously. They can't even take the breaks. They have to be wearing the PPE, and they ended up the pressure source like that on the face. So this is all the nurses or the staffs. They're looking after the COVID patients. This is the latest one. So again, looking after your skin is very important. Keep hydrate yourself, and if possible, try to take the mask off. If it's too much causing pressures, take time off. That's the only thing you can do. So look after yourself. That's the most important thing. And especially if you have to wear the glasses or the hearing aids, take care of those things. And prevent the anything which is causing from the friction. Finally, the summary. So pressure ulcers are commonly encountered in patients admitted to the hospital and those in the long-term care facilities. Older people are the more prone, so take care of them, especially when you do the risk management. And using support surfaces, repositioning the patient, optimizing the nutrition status, moisturizing sacral skin are appropriate. So strategies to prevent the pressure ulcers. So overall, if you manage the skin bundle as a skin very carefully, so that itself will prevent the pressure damage. So this is the Waterloo score. Rajendra will like to take this quiz. Rajendra?
Yes, thank you. Just a quick case study. Whoever is having the able to access the Waterloo score individually on their laptop or desktop or the mobile, they can answer this question. And the candidates from the SS hospital, because they use the common screen, I don't think so they'll be able to access this one. But still, you can try to your level best in your own time, and we are going to share this slide in the post evaluation or personally at later stage. We'll attach to your email. So case study: a 79 years old obese female patient admitted to ICU with a diagnosis of COVID-19 and heart failure, and she's having a history of hypertension, CCF, diabetes. On examination, skin is intact but edematous, and she is double incontinent. So needs assistance of one to mobilize, and complaining of lack of appetite since 3 weeks. So your task is that, based on the case history, identify the risk score by using the Waterloo score. So we have the body weight, skin type, age, malnutrition screening, continence, mobility, and the special risk area. So we want you to calculate what is the Waterloo score for this 79 years old lady. So you can take it as a homework, because a few of them they're coming through the Facebook and few are coming through the YouTube. So it's hard to assemble compile all the results in one area.
I think the best thing is if they can take a screenshot.
So in your own, you can use this one. And if you have any queries, please send the email and we'll get back to you. Okay, thank you. Sure, back to you, please.
Back to me, thank you. Okay, any questions? You can either ask or you can put on the chat box. So we'll try to answer that.
Either raise your hands.
Yeah. Okay. Rajendra, would you like to take this question?
Yeah, no problem. Can you stop the share screen? Share screen. What is it? Screen sharing, please.
Shivanand,
Yes.
can you stop sharing screen?
Once again.
Okay, so blanching test, how we are doing this. Before that, you should have the basic idea of what is capillary refilling time. So, example, if you press the skin for 5 to 10 seconds, okay, and release, and if there is a skin color change, for example, because you are pressing against the capillaries and there is a temporary occlusion of the blood circulation to that affected area. So what you can do is that press and hold for 10 seconds, count, then release, and there should be a reblanch. So the blanching should disappear, so that when you press, there will be a kind of discoloration, the whitish discoloration. The moment you will release, within 2 seconds, the color, the red color has to come back. If it color has come back, means there is a good perfusion. The capillary perfusion rate is good. That is CRT, that capillary refilling time is good, and there is no problem with the circulation. But after pressing for 10 seconds, when you take off your finger, and if you see still there is a whitish discoloration, that means there is a problem with the circulation, and the patient is high risk of developing the pressure ulcer. And that can be checked. Usually it will happen at the sacral areas, or depending upon the position of the patient, in which position the patient is lying. Yeah. So larval therapy, what happens is a sterile larvae. It's a maggots actually. So it will be used. So it needs a specialized training, and the specialized tissue viability nurse will come, he or she will come, and they will introduce the sterile larvae on the wound. So what this sterile larvae will do, they'll engulf, or they'll eat all the dead tissues or debris, and after certain time, all the larvae will be counted back, and it will be taken away from the wound. So that is one of the wound cleansing method, but needs extensive training for that one. I think.
Okay, my question is, we are using a water bed in ICUs and neuro patients, water bed and air bed as well. How about using those things? Because you are showing the different kinds of beds in the slides. Very good cushion beds. How about using a water bed in ICUs?
Water bed. Sorry, Shivanand, please continue, sir.
So yes, the main important thing here is air mattress, soft forms, or the water bed. Main important is changing the position of the patient. If the patient is high risk, so you need to be changing the positions. So those are the important thing. So before this air mattress came, we never had before this water bed, there was no air mattress bed at all. So we used to treat the patient on the water bed. So the main thing is changing the positions, nutrition and hydration, and treating the sepsis if there is any sepsis. So even not all places got the specialized those mattresses which we showed in the video. It's not available in not in all the places. So it is available in few places, but it is pressure redistribution mattresses. So if you got the air mattress, the water bed, it's fine. But the thing is changing the positions, supporting the bony prominences, good nutrition, and the hydration. These are the main things we have to be considering. So if you take the slide of those S skin, those are the five acronyms. If you manage that, so you're preventing almost like a 95% of the pressure sore.
The other question is, can I ask other question?
Yes,
we
please.
use diapers in ICUs, isn't it?
Yes.
Diapers can cause a wound.
Yes. Yes, the diapers, what happens is we try to avoid using the diapers, especially the patients with the incontinence of the feces or the urine. The reason is the diapers, what happens when the patient is wet, incontinent, so the diapers absorbs the moist, and the excess moist is causing the maceration or the skin excoriation if the patient is already developed the pressure sore. So try to keep you need to keep an airflow. So especially the patient got the incontinence, try to keep the airflow. So keep the patient clean and dry. Cover him with the sheet, but so they needs to have an airflow so that the wound can heal quickly. So we have seen here some patients they're putting the in-course sheet on the air mattress. So we've been introduced that not to use the in-course sheet. I know it helps to prevent saving the bed sheet getting dirty. So I know it happens, but it is not going to help with the patient's skin, especially when you clean the patient, you keep the patient clean and dry, and you put the barrier cream, and then if you put the pad, so there is no point because the pad is absorbing all the cream. It's not going to help. The patient's skin is getting it's like a treatment. It's like a medicine working on the skin. So it depends on the patients. If there is an incontinence, try to avoid putting the diapers. Keep the patients clean and dry. Cover with the sheet. Let the airflow happen so that the wound can get better soon.
What is that absorbent sheet you said once more, please? You said some absorbent sheet, isn't it? You put under the...
that is called a in-core sheet. In-core is like a thin layer of the absorbent sheets. We call it as an in-core sheet.
So we can avoid putting the diapers for those if you use that, isn't it? Okay.
If
Not
patient
really.
got the
It
diarrhea.
depends upon the condition to condition system. Because if the patient is for example, patient is incontinent of urine, it's always advisable to use the diapers, that is nappies or pads. Or if the patient is double incontinent, and if the patient is if the patient is developing the moisture lesion because of the fecal incontinence. If the fecal incontinence is extremely loose, if the patient is having the C. diff, and if the patient is having extreme loose stool, then in that case, to maintain the skin lesion, to enhance the skin lesion recovery, what you can do, you can use the rectal tube, or you'll have this special device that will be introduced to the rectum directly. So whatever the fecal is kind of putting the instead of the catheter, we're putting the rectal catheter. I can say in single word. So all the feces will come to the bag. It will work only if it's completely loose stool. So that will be that one tube can be remain in place for 3 to 5 days. Only we need to change the bag.
Okay.
They are very good. Before the skin breakdown itself, will be applying when the patient is at risk of developing the pressure ulcer. So we'll be applying these, especially the Cavilon or the other skin barriers. So it will prevent the skin break in the initial stage.
The one important thing, sister, if you come across any patient with the incontinence in the ICU or in the ward setup, the most important thing you will be considering is whether the patient can we catheterize him. So your main thing is keeping the patient clean and dry and minimize your work also. So if you can manage to, like, a patient can be catheterized for until his incontinence problem is resolved. So if the patient has got double incontinence, fecal incontinence, try to put the rectal tube, as Rajendra said. If the patient is incontinence of urine, you can try to put a short-term duration of the catheter until medical condition is improved. So, and in the same time, you will use the barrier creams. And again, this is one of the medical device. When you put the catheter, that itself is not going to resolve his pressure. So take care of those tubes. The patient is not lying on the tube, and again it will be causing a pressure sore.
Again, tape on the ulcer, isn't it? We used a lot of tape to fix the catheter. Putting the catheter, taking a catheter, that is also a problem. That's what,
Yes, this is true, especially what we call
tape-induced ulcer. We've seen lot of tape-induced ulcers, skin ulcers, superficial ulcers.
Can I suggest we no longer use the tape for securing the catheters now. We use a strap now.
Okay.
There is a strap that comes around to secure the catheter around the thigh. So you don't secure the catheter directly to the patient.
Yeah, but that may be not available in every place.
So the idea, let me just summarize. Shivanand has given a very practical approach of what is being currently adopted in UK. I think it is time for you guys to look at what is available in your areas, what is currently being practiced, how you are implementing this, what are the resources that you need to be thinking about, what assessment criteria you have, do you have those barrier creams that we mentioned, and what can you do differently to improve, make improvements.
That's right. Thank you.
Sister, there is a package is available called as the Pressure Ulcer to Zero Initiative. Hello?
Not seen on the camera.
Sister, can you hear?
Yes, I can hear you.
Yeah.
So, go on.
If you're really interested to implement some kind of change, a new mechanism of dealing with the pressure ulcer, please let us know, sister. So our GINA team can help you to initiate one program called as Pressure Ulcers to Zero Initiative.
Okay.
So we'll give the required resources and education. If you give one particular ward, either it may be medical ward or surgical ward, any one ward, and if you tie up with that ward with our GINA team, so we'll educate the staffs on that particular ward to implement this program, and you can compare the whatever medical ward versus rest of the hospital ward. What is the prevalence rate after the introduction of this program? So we can give all the study materials and we can educate the staffs of that particular department.
Okay, thank you.
Any questions from anyone else? Any questions from any other staff members?
Questions, sir? Naresha?
Or even the other participants? There are 51 other participants in total from different places, not just down here.
Okay.
Okay. Please raise your hand, or you can unmute yourself and ask a question.
Question either. How to
do the position to the pain injury patient.
Okay, there is a question, Swami.
Yeah.
How to position a spine injury patient?
Spinal injury.
The source, because you are telling change the position 2 to 3 hourly, 4 hourly. So spine injury patient, how do we do that?
Okay, there is a procedure called log roll system. Are you familiar with the log roll system?
No.
Okay, so that's a completely different I may have to demonstrate that procedure to you by a video link. Probably what I will do is I will get the video link for you next time. You can have a look at it on the YouTube itself. Look for log rolling, spinal injury log roll. There is plenty of videos. I suggest you.
Fine.
So if you watch out for a log roll, that's what you should follow for spinal injuries.
Okay, fine.
Yeah.
We need 4 people to do the log
minimum
roll.
of 4 people, 1 to protect the spine, 1 to protect the back, and 1 to protect the hip, and 1 to protect the leg.
Okay.
And the person who is holding the spine is the person controlling the log roll. He gives the command, and the other 3 will follow the instructions. Yeah. Okay. Any other questions?
Any question? Okay, that's it from our side.
I want to share it.
Sir.
You just now said log roll.
Yes, sir.
You know, log. It's a stem. How we move, we can't twist it. We cannot twist it. We just roll it. In the same way, we have to roll the patient. That's the log roll.
Oh, Ravi. Okay.
That's right. Yeah.
Because he has got injury there. Unnecessary movement is accepted, especially those who are having spinal injuries.
Yeah.
They should be log rolled. The log, when a big tree, the cut tree is there. You can't twist it. In the same way, if you roll it, in the same way, we have to roll the patient. We are not supposed to twist the patient's body.
What sir was trying to say was, imagine a long tree. You cannot bend a tree, so you have to turn the whole thing.
Today, what we are seeing, 6 and 6 there.
Yeah. So you have to move the whole patient. You cannot bend the patient. So hence you need 4 people to do it all together.
Okay, we'll see the video, and if you have any confusion, you can demonstration and one class.
Yes, we can.
Do the demonstration.
The one of the disadvantage of doing a virtual presentation is that we cannot do a live demonstration. We can only probably do a video. We can only do a video presentations.
Okay.
So that's the only drawback of this one.
Okay. Swami, you want to say something? Sir is here with us.
Sir, namaskar.
Sir is here. Can you see him?
Yeah.
Sir.
Yeah, good afternoon.
Namaskar, sir.
Namaskar. Good afternoon.
Good afternoon.
Nice to see you all.
Thank you, sir.
I hope things went well so far. In fact, we are really privileged to have you all on the panel, and it's really helping all our staff members here. And they were sharing about the last class.
Yes, sir.
So I told them, no, the same thing has to be repeated, because at given point of time, we'll not be able to provide all the staff nurses.
Yes, sir.
So those who are already on work, duty, they will miss this class.
Yes.
And another thing is, if possible, I hope there is a provision for recording the same session.
Yes, sir.
If there is a provision, can you just put it onto the YouTube and share the link to us so that we can circulate in the staff nurses WhatsApp group?
Yes, sir. We have both the sessions were recorded last week and this week.
Yeah.
I'll share the recorded version to you, sir.
Thank you. That will be nice, because those who have missed and those who are not attentive right now, they can also go through once again.
Yes, sir.
Okay. Thank you very much. From the administrative side of the institute, we are really thankful to the entire team in UK. You are taking a lot of pain in conducting all these classes. I hope this will be of a great help to our staff nurses.
Thank you so much, sir.
Thank you, sir.
Thank you.
For your kind participation.
Thank you.
So 11 o'clock, 4 o'clock in the morning for them. They woke up at 4 o'clock and they are sitting to teach us. And Tipeswami is not well as well. He's not well.
Is it? Are you not?
COVID, sir.
He's positive.
Oh,
And he's having cough, fever. He's talking there.
please take care. Please
Thank you,
take
sir.
care.
Thank you,
Huh?
sir.
Have they started? CT has been done for you?
Right, sir. Yalla aitu. Day 15 today.
Okay, day 15. Okay.
He'll be back to work tomorrow, I think.
Yeah.
You Rajendra, sir.
Okay. Nice,
Namaste,
nice.
sir.
meeting. Yeah, namaskara.
Sir,
Thank you. Thank you.
I do remember you, sir. We used to go in Davangere when you were in CHI. We worked with you, sir, in Pulse Polio program.
Right.
Long before, sir.
Long before. Yeah. Almost 25 years old.
Nearly more than 20. No, nearly 18 years, I think, sir. 18, 20 years.
Okay. Right. I think somewhere around 1999, 2000, I believe.
It's around 98, 99, I think, sir.
They left
98,
before
99,
that. They
yeah.
left before
Okay.
that.
Yeah. I used to regularly take classes.
Yes.
All BSc classes. Thanks, students. Okay. Nice seeing you all.
Thank you very much for your support, sir. Thank you.
Really, we appreciate your concern towards us. This will help a lot.
Sir, ಏನಾಗುತ್ತೆ ಅಂದ್ರೆ we can only give some ideas ಅಷ್ಟೇನೆ sir, but it all depends on what can be implemented at the hospital level.
Yeah, I know.
There is going to be resource issues, training issues ಇದ್ದೇ ಇರುತ್ತೆ. It is something for you to look into and then see whether we can come up with any ideas and any suggestions that you want us to make. Then we are happy to contribute to that. Please do let us know.
Yeah, definitely.
Sometimes what may teach may not be the right things for the staff, but it is up to the staff to take that responsibility and ask us those questions so we can improve ourselves and tailor it according to your needs.
Come and join our nursing team here, so you can improve. You can come and join here.
See, this is what the people ask.
Provide the UK package, we'll join you.
Administrator is here. Ask him.
No, I don't think the issues what you had faced about 20 years back, that is not true today. The facility, resource is not the dearth today. Everything is possible here.
Yes, sir.
Issue is, only thing is you need to have a little bit of mindset to work for that and make use of the facilities. And this is a initiation. See, they can just see you. That itself will stimulate a lot. There are many of your classmates are here. So they just seeing at you and looking at the position, all those things will stimulate. And it takes to a different level. I hope this is a good initiative. In coming days, definitely it will help a lot. Okay. And from our end, we will also start, taking certain things. You can watch from your end and say that how best they are doing here.
Yes, sir.
We will also send you the link, and we will also arrange some, sort of classes from our staff. You can just, witness it and say what way they are doing.
Yes, sir.
That's good, sir. That's a very good initiative.
Thank you very much.
Okay.
Thank you very much. Thank you, everybody. I hope it was useful.
Yeah.
It was useful. Thank you, Shivanand.
Thank you, madam. Thank you.
Thank you, everyone. Thank you, sir.
Thank you, Suresh.
Thank you very much. Thank you.
Thank you.
Thank you.
Sir.
Thank you.
And I would like to ask, we need to thank you to Rajendra as well, because equally he has helped in making this presentation. So thank you, Rajendra. Yes.
coffee.
Thank you.
Thank you, Suresh, for all your support.
Thank you.
ಯಾರಂತ ಗೊತ್ತಿಲ್ಲ ಅದು.
No, actually, Huli sir, he's left. I think he is trying to join again. I think technical issue.
Sir.
No, actually, he joined again. He left, and again he's trying to join again.
Yeah,
I think there's a
because,
problem
you know,
with the network.
Actually,
Yeah.
I was busy with my class. When I saw
Okay.
that they were coming, immediately I stopped my class. I told all my students, come on, put on your mobile. They all started listening. I show you that everything, all the students, something I shown you people. I hope, I don't know whether you observed it or not.
Yes.
Yeah, I was just, I was taking class on different topic. I just stopped it. Then I told everybody, open your mobile. Come on, see the important topics. This is the most important for your future working aspect.
CGH.
They felt very much happy to see. They enjoyed.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
ರಿಟೈರ್ ಆಗಿ ಬಹಳ ದಿನ ಆಯ್ತು. ಹುಬ್ಳಿನಲ್ಲಿ ನಡೆಸ್ತಾರೆ.
It was so very nice presentation. Really, I enjoyed it. In between, I just went up because there was a birthday celebration. Some of our staff, I had to go there. So I just temporarily, though it was on actually, attended and come back. Could not say no also.
Sir, Kalapa sir, Uli sir is currently working in Parul University as the Dean of Nursing in Parul University, Gujarat.
ಅಲ್ಲಿ ಹೋದ್ರೇನು?
And he's originally from Belgaum, and he was our teacher for both Rajiv Gandhi and so he's been he's hosted our first event, sir, very first event of early warning signs. There was about 1,400 attendees, sir. 1,400 attendees idru, sir. EWS launch ಮಾಡಿದಾಗ last month.
Okay,
So,
nice.
It was a grand success.
Program is appreciated by many people here,
Yes, sir.
including our vice chancellor and everybody. They liked it.
Yes.
He wants to participate in our program,
Yes.
but here I can't bring, so I just kept cut. I want to be in our program. He kept on telling me, but I can't get it because everybody should get the rotation.
Okay.
Thank you, everyone.
Thank you.
Thank you.
You all take care.
Thank you very much.
Thank you very much. Thank you. Thank you.
Okay, thank you.
Thank you very much.
ನೀನ್ ಬರಪ್ಪ
ಚಿದಾನಂದ್ ಇಲ್ಲ.